Hello students, in today's video we are going to study pharmacology of azole class of antifungal drugs. Now this class of drugs are most extensively used broad spectrum antifungal drugs. Now these drugs treat superficial as well as systemic fungal infections. So now let's first understand classification of azoles. Now azoles are classified into two categories, imidazoles and triazoles. Now imidazoles are further divided into two subgroups, drugs that are used topically and drugs that can be used topically as well as systemically. Now these four imidazoles, namely clotrimazole, iconazole, miconazole, oxyconazole are used only topically, while ketoconazole is used topically as well as systemically by oral administration. Now triazoles are used only systemically, either they are used orally or IV. Now these are fluconazole, itraconazole, voriconazole and posaconazole. Now after classification, let's understand mechanism of action of azoles. Now azoles are fungistatic, that means they inhibit the growth of fungus. Now imidazoles and triazoles, they all have the same mechanism of action. Now these drugs prevent synthesis of fungal cell membrane. Now look at this figure, it represents structure of a fungal cell membrane. Now like the human cell membrane, fungal cell membrane is also made up of these two phospholipid bilayer. Now an important critical component of fungal cell membrane is the ergosterol. Now these ergosterols are not present in the human cell membrane. Now fungal cell synthesize ergosterol from squalene. So squalene produces lanosterol and lanosterol produces ergosterol. Now lanosterol, in the presence of enzyme lanosterol 14-alpha demethylase, produces ergosterol. Now very important that this lanosterol 14-alpha demethylase is a fungal cytochrome P450 enzyme. Now azoles inhibit lanosterol 14-alpha demethylase, and inhibition of this enzyme impair the synthesis of ergosterol, and this results in a series of abnormalities in the fungal cell membrane. So the permeability of the fungal cell membrane increases and substances from the cytoplasm of the fungal cell, they pass out or they leak out of this fungal cell membrane, and this results in fungistatic action. Now another important point to understand here, that cytochrome P450 enzymes, they are also present in the human body. So azoles inhibit cytochrome P450 enzyme, and thus they produce a number of interaction with several drugs. So now let's understand pharmacology of drugs covered under azoles. Now let's first discuss pharmacology of imidazoles. Now as discussed, clotrimazole and miconazole are used only topically. Now let's first talk about clotrimazole. Clotrimazole is very effective topically for superficial fungal infections, which include tinea infections and superficial candidial infection. So it is a first line drug in the treatment of tinea pedis, that is a tinea infection of foot, also known as athlete foot. Then tinea cruris, that is the tinea infection of groin, also known as joke itch. Then tinea corporis, that is also known as the ringworm infection, and it can affect any part of the body like trunk, arms or legs. So apart from the tinea infections, clotrimazole is also a drug of choice in the treatment of vaginal candidiasis, and it also effectively treats cutaneous candidiasis, and in the treatment of oropharyngeal candidiasis, it is used as a thrush or it is used as a lozenge. Now topical clotrimazole can cause local irritation with burning and stinging sensation at the site of application. However, no systemic toxicity is seen after the topical used. Now, next topical imidazole is the miconazole. Now, like clotrimazole, topical miconazole is also efficacious and it is also a first line drug in the treatment of superficial tinea infection, that is tinea pedis, tinea crurus, tinea corporis. Now, apart from these tinea infections, it is also effective against pityriasis versicolor, which is also known as tinea versicolor. Now, in this tinea, small discolored patches are produced on the skin, and this occurs because fungus interferes with the normal skin pigmentation. And like clotrimazole, it also effectively treats vaginal candidiasis, and it is also very effective in the treatment of cutaneous candidiasis. Now, local irritation can occur at the site of application. However, no systemic toxicity is seen after the topical use. So, topical imidazoles are basically or primarily used in the treatment of tinea infections and in the treatment of superficial candidial infections. Now, a very important point to be noted over here is this, that if these tinea infections or if these candidial infection, they do not remain localized, or we can say they spread, or they are not treated or they are not cured with the topical imidazoles, then along with the topical drugs, oral azoles are also used. So, this was about clotrimazole and miconazole, that is topical imidazoles. Now, next imidazole drug we are going to study is the ketoconazole. Now, ketoconazole can be used topically as well as systemically by oral administration. So, when it is given orally, it is absorbed in the blood and it reaches all the parts of the body. So, clinically, ketoconazole is used for superficial infection, that is dermatophytosis or the tinea infections. So, ketoconazole, topical ketoconazole is used for the treatment of dermatophytosis or the tinea infections, and systemic ketoconazole is used for the treatment of systemic mycoses, that is systemic fungal infections, which where the fungus affects the internal organs of the body, like for example lungs, heart, etc. However, very important to understand here that oral use of ketoconazole is highly restricted because of its potential adverse effects. Now, oral triazoles like fluconazole and itraconazoles are used for systemic mycoses or systemic fungal infections instead of ketoconazole because of their greater efficacy, longer half-life and fewer side effects. Now, again, you should know that topical ketoconazole is very effective and it is used for the treatment of tinea versicolor. Now, let's discuss the pharmacokinetics of ketoconazole. As we have already seen that it is administered orally. Now, its oral absorption is facilitated by gastric acidity. Then it shows high plasma protein binding of 99% and its plasma half-life varies from 1.5 to around 6 hours. Now, penetration in the cerebrospinal fluid is poor. It is extensively metabolites and metabolites are excreted in urine and feces. Now, let's talk about the adverse effects of ketoconazole. Now, because of these toxic effects, the ketoconazole, use of oral ketoconazole or use of systemic ketoconazole is highly restricted. So, when used orally, ketoconazole can cause gastrointestinal symptoms like nausea, vomiting. It can cause other symptoms like loss of appetite, then headache, then paresthesias, that is occurrence of abnormal sensation like tingling or prickling sensation can occur. Then it can cause rashes, hair loss. Another major adverse effect of ketoconazole is its hormonal effects. It can cause gynecomastia in males due to reduced synthesis of testosterone, and it can cause menstrual irregularities in females due to reduced synthesis of estradiol. It also reduces synthesis of hydrocortisone. Apart from this, it is also hepatotoxic, and its use is contraindicated in pregnancy and lactation. Another very important point, ketoconazole and most of the azoles, they inhibit cytochrome P450 enzyme, and thus they interact with a number of drugs. Now, ketoconazole, by inhibiting cytochrome P450 enzyme, inhibits metabolism and therefore increase the plasma concentration of several drugs like warfarin, simvastatin, cyclosporine, etc. And it produces serious drug interaction with drugs like terfenadine, acetymazole and cisapride, and it can even produce ventricular tachycardia. So, ketoconazole, even though it can be used both orally as well as topically, primarily it is used topically for the treatment of tinea versicolor, and oral use of ketoconazole is restricted because of its adverse effect profile. So, now let's talk about the triazoles. So now after imidazole, let's study pharmacology of triazoles. Now the first and the very important triazole is a fluconazole. Fluconazole is used both orally as well as IV. Now let's see to the clinical uses of fluconazole. Now fluconazole is very effective in the treatment of superficial as well as systemic candidiasis. Now if oropharyngeal candidiasis is not treated with nystatin or clotrimazole, then the next very effective treatment for oropharyngeal candidiasis is the fluconazole. Then fluconazole is a drug of choice in candida esophagitis, that is candidal infection of esophagus. Then again, as we have already discussed, vaginal candidiasis is treated with clotrimazole or miconazole. If vaginal candidiasis is not cured by topical imidazoles, then again fluconazole is the drug of choice, and fluconazole also effectively treats cutaneous candidiasis, and it is also very effective in the treatment of systemic candidiasis after echinocandins. Now then again fluconazole is a drug of choice in the maintenance therapy of cryptococcal meningitis in the AIDS patient. Now, cryptococcal meningitis is treated initially for the first 2 weeks by Amphotericin B and flucytosine. So, this therapy is called as an induction therapy. Now, after 2 weeks of induction therapy, the patient is given maintenance therapy of fluconazole. So, fluconazole is the drug of choice in the maintenance therapy of cryptococcal meningitis in the AIDS patient. Then, as already discussed, if tinea infections, they do not remain localized, they spread, or if they are not treated with the topical imidazoles, then fluconazole is very effective in the treatment of tinea pedis, tinea cruris and tinea corporis. Then it is also effective in the treatment of histoplasmosis, blastomycosis and sporotrichosis. Even here I wish to tell you that itraconazole is a drug of choice in these fungal infections, but after itraconazole, or if the itraconazole is not available or if it is not tolerated, then fluconazole is also found to be effective in the treatment of histoplasmosis, blastomycosis and sporotrichosis. So these are the clinical uses of fluconazole. Now pharmacokinetics of fluconazole. Fluconazole has a very good oral absorption. It is widely distributed and it has good penetration in the cerebrospinal fluid, and therefore it is the drug of choice in the maintenance therapy of cryptococcal meningitis. Now it has a long half-life of 25 to 30 hours and its plasma protein binding is approximately 10%. Then it is excreted unchanged in the urine, and therefore this point is very important, and therefore dose reduction is required in patients with renal impairment. Then adverse effects of fluconazole. Fluconazole produces fewer side effects, and the common adverse effects are nausea, vomiting, abdominal pain, rashes and headache. Hepatotoxicity can occur in AIDS patient, and it is contraindicated during pregnancy and lactation. Then fluconazole inhibit the enzyme cytochrome P450 enzyme, and thus it shows drug interactions, but the drug interactions are lesser compared to that of ketoconazole, and by inhibiting the metabolism of drugs like warfarin, phenytoin, cisapride, astimazole, it increases their plasma concentration, and ventricular tachycardia has been reported due to the interaction of fluconazole in with the cisapride, and as discussed, it is not to be used during the pregnancy. So fluconazole is a widely used triazole, and it is very effective in the treatment of superficial as well as systemic fungal infection with a long half-life and fewer side effects. So this is the pharmacology of fluconazole. Now another very important drug is the itraconazole. Itraconazole is also a triazole. It is also administered orally and IV. Now let's discuss the clinical uses of itraconazole. Now itraconazole is a first choice drug in the treatment of histoplasmosis, blastomycosis, sporotrichosis, paracoccidioidomycosis and chromomycosis. Now itraconazole is also very effective in the treatment of vaginal candidiasis. If as already discussed, vaginal candidiasis is a superficial infection, and it is first treated with the clotrimazole and miconazole, but if it is not treated or if it is not cured by those drugs, then itraconazole is very effective. And similarly here also in dermatophytosis, that is the tinea infections, if they are extensive or if they are not treated with the topical imidazoles, then again itraconazole is very effective. Now itraconazole is also effective in the treatment of onychomycosis, that is a tinea infection of nails, but relapse can occur, and some relief is also provided in aspergillosis by itraconazole. So these are the clinical uses of itraconazole. Now let's discuss the adverse effects of itraconazole. Itraconazole can cause gastric intolerance. It can produce dizziness, pruritus, headache and hypokalemia. It is also hepatotoxic, and it should also not to be used during the pregnancy. Then pharmacokinetics of itraconazole. Now pharmacokinetics of itraconazole is different from that of fluconazole. Now its oral absorption is enhanced by the administration of food and gastric acid. Now unlike fluconazole, which was approximately 10% bound to plasma proteins, itraconazole is 99% bound to the plasma proteins. Then unlike fluconazole that had good CSF penetration, itraconazole does not penetrate the cerebrospinal fluid, and again it has a very long half-life of 30 to 64 hours, and it is largely metabolized, and unlike fluconazole that was excreted in the urine, itraconazole is not excreted in the urine. So these are the important pharmacokinetic features of itraconazole. Now drug interactions. Itraconazole shows drug interactions with several drugs. Now drugs like rifampin, phenytoin, phenobarbital, they increase metabolism of itraconazole, and thereby these drugs reduce plasma concentration of itraconazole. On the other hand, drugs like clarithromycin, HIV protease inhibitors, they inhibit metabolism of itraconazole, and thereby they increase the plasma concentration of itraconazole. Now in addition to this, like fluconazole, itraconazole inhibits cytochrome P3A4 enzyme, and its drug interaction profile is similar to that of ketoconazole. So this is about the pharmacology of itraconazole. Now next azole is the voriconazole. It is a triazole. Voriconazole is a newer triazole. It is also administered orally and IV. Now let's discuss first clinical uses of voriconazole. Now voriconazole treats difficult fungal infections, or we can say non-responsive fungal infections. So it is a very broad spectrum antifungal agent. Now voriconazole is a drug of choice. This you need to remember. This you must by heart, that voriconazole is a drug of choice for invasive aspergillosis, and it effectively treats fluconazole resistant systemic candidial infections. It also treats serious infections which are caused by fusarium species like onychomycosis, that is the tinea infection of nails, skin infections and keratitis. Then in addition to this, voriconazole is also effective in the treatment of fungal infection in febrile neutropenic patient not responding to the antibiotic therapy. So voriconazole is very effective. It is a very broad spectrum antifungal drug. It is a newer triazole, and it is used in the treatment of non-responsive or difficult to treat fungal infections, and it is a drug of choice for the treatment of invasive aspergillosis. Now let's discuss pharmacokinetics of voriconazole. Now voriconazole shows good oral absorption. It's widely distributed in tissues, and it also reaches the cerebrospinal fluid. Its plasma protein binding is around 16%. And unlike fluconazole and itraconazole that had long half-life, its half-life is only 6 hours, and it undergoes extensive hepatic metabolism, and metabolites are excreted in the urine. Now, unlike fluconazole and itraconazole, voriconazole exhibits potential adverse effects. Now, voriconazole can cause vision changes, like it can cause abnormal vision. It can cause appearance of flashes of light, like appearance of small sparkle like lights or small sparkles in the field of vision. Then it can cause photophobia, that is abnormal sensitivity to light, and it can also cause color change. So voriconazole can cause abnormal vision, and these abnormal changes, they start within 30 minutes of administration of voriconazole, and these symptoms, they last for around 30 to 60 minutes. Then voriconazole can also cause neurotoxicity, which can cause symptoms like visual hallucinations, confusions, agitation, etc. It is also hepatotoxic. It can cause acute reactions when it is given by IV, intravenous route. It can also cause QT prolongation, causing arrhythmias. It can also cause photosensitization. Rarely it causes adrenal insufficiency. Then like other azoles, it also inhibits cytochrome P450 enzyme, and it can cause drug interactions, and its drug interaction profile is similar to that of ketoconazole, and it is also contraindicated in pregnancy. So here very important to remember that voriconazole is a newer triazole. It is a very broad spectrum antifungal drug, and it is a drug of choice in the treatment of invasive aspergillosis, and it is associated with potential adverse effects. Now the next triazole is the posaconazole. Posaconazole is also a newer triazole, and it has also a very broad antifungal spectrum. It is administered both orally as well as IV, and it is very effective in the treatment of mucormycosis. Now since posaconazole is a newer triazole, and because of its high cost, its limited experience, Its use is reserved for non-responsive or for refractory cases of aspergillosis, invasive candidiasis, febrile neutropenia, that is a candidial infection in the febrile neutropenic patients, and it is also used as an alternate to itraconazole for the treatment of chromomycosis. So these are the clinical uses of posaconazole. Then some important pharmacokinetic features. Its oral absorption is improved by acidity, that is by the low pH in fatty food, and its plasma protein binding is around 98%. It is excreted mostly unchanged in the feces, and its plasma half-life is more than 24 hours. Now, adverse effects of posaconazole are less than that of voriconazole, and common side effects are nausea, abdominal pain, loose motions, headache, dizziness and drowsiness. Rarely it can cause anemia, neutropenia and cardiac arrhythmias. It is not to be used during pregnancy, and like other azoles, it also inhibits cytochrome P3A4 enzyme. So this is in brief on pharmacology of azoles. So as we have discussed, azoles are broadly classified into imidazoles and triazoles. Imidazoles can be used, are primarily used topically for the treatment of superficial tinea infections and superficial candidial infections, except ketoconazole, which can be used systemically as well as topically. And apart from the imidazoles, triazoles are used orally or IV, and these are very effective for the treatment of superficial as well as systemic fungal infections. So this is about the azoles. So please note that the information provided in this video is only for informative academic purpose. For the use of azoles or for the treatment of fungal infections, consult your physician. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.